rural health panel for the last 20 years, and I'm a professor at Washington University, and my work focuses on health insurance issues. And I'll be doing this presentation today with Abigail Barker, and she'll introduce herself now.
Hi, thanks everyone for joining the webinar today. I'm Abigail Barker. I also do health policy analysis for RUPRI for the past several years, looking at various questions related to understanding how market structures may work differently in the health insurance market in rural areas. I am a research professor at Washington University. So before we begin, just a couple of quick remarks to say that this webinar is supported by RUPRI through a cooperative agreement with the Federal Office of Rural Health Policy, the Health Resources and Services Administrations, and the U.S. Department of Health and Human Services. Before we begin, could you please mute your microphone, disable your video, and if you're calling in, please mute your phone to avoid any background noise during the webinar. There will be time for Q&A at the end of the presentation, so please do email any question that you may have to me at arbarker@wustl.edu, and that's also up on the slides. In case we don't get through all the questions during the scheduled webinar time, we will have your contact information and we'll be able to follow up with you by email. And also a recording of this webinar will be available at www.rupri.org. All right, so I think we're going to kick it off now.
Okay, great. We're excited to talk to you today about, okay, sorry. Here's the outline of what we're going to be talking to you about today, and we're going to go through some background, economic theory, rural specific issues, and real world impact. And really our key question we're going to be focusing in on is what are the similarities between the markets that face rural people. In particular, there's the rural health insurance markets, both the marketplaces under the ACA, the Medicare, Medicare Advantage markets, Medicaid, private insurance, FEHBP, and we're going to be drawing parallels between the rural challenges they face and what lessons can we learn from those. So to start with some of the motivation, this slide sort of shows you that something that you probably have seen in the popular press. There's been a lot of attention to the lack of health insurance options in some rural counties at various points in time. This shows some headlines that have focused in on the lack of choice in the Obamacare programs, the marketplaces. And again, the key point is that there's challenges facing rural people in areas with a lack of choices. And one more slide on the marketplaces. Another motivational point is that this slide is a little dense, but basically it shows the percentage increase in premiums before the subsidies for the second lowest silver adjusted premiums, silver plans. And on the left-hand side is the least dense areas, and on the right-hand side is the most dense urbanized areas. And one thing to focus in on is probably the orange and silver bars in particular. That's the 2016 and 2017 numbers. And what you see there is the premium increases were highest on the left and lowest on the right, which means that they were highest in rural areas and lowest in urban areas. In 2017, 2018, I mean, for the last bar is pretty even across the whole country, sort of a lot of turmoil in those marketplaces. We don't have the numbers differentiated by geography for 2019, so we don't know exactly what that looks like, but one of the key takeaway points for this is the higher increases in rural areas. Looking at this sort of draws one of the parallels that we want you to see is that there's parallels between Medicare Advantage on the left and the ACA marketplaces on the right. So on the left you see Medicare Advantage, and it shows the numbers of counties, the counties with no Medicare Advantage insurers and potentially no marketplace insurers in 2018. So they're all rural counties essentially. and the no Medicare Advantage insurers are dark blue, and the potential Medicare marketplace insurers in 2018 were the orange, and those with both were in the light blue. Now it eventually ended up that those counties did have marketplace plans, but they're, really the main point of this, and the one on the right is to show you that where the darker blue shows number of exchanges that lost insurers, orange being 0, and then 4 being the darkest, being the most insurers lost, is mostly a rural issue. So moving on to one more motivational example from the work that Abby and I and others did on the Federal Employees Health Benefit Plan a few years ago, to sort of show you that this pattern follows across other insurance plans. So if you look at the number of counties that have 900 counties have 0 to 1 state-specific plans offered. And so the way the FEHBP plan works, if you don't know this, is national plans are offered everywhere, but they can also offer state-specific plans if possible. But as you can see, in 900 counties, again, mostly rural, if not all rural, they offer either 0 or 1 state-specific plans. And then if you look at the far right-hand column of this table, you can see that almost all people are choosing the national plan. And it isn't until you get to about counties that have 3 or more state-specific plans that people start to choose something other than the national specific plans. It goes from 65% to 41 to 19 to 2. So again, it's what this is basically showing is the availability of state-specific plans affects choice, and that's really an urban issue. So the goal of our presentation today is to get behind some of those numbers across. One of the points of those few slides was to show you that these factors are affecting all sort of markets that have private options to public plans and Medicare, Medicaid, marketplaces, and so on, and discuss possible solutions to this. So I'm going to give you a little bit more background on some of this, and then we'll dive into some of the economic background on this as well. So in the 1980s, with the implementation of Medicaid, Medicare, and FEHBP, there was rising concern about healthcare costs and how to get control over that. And the options of shifting to private companies through a capitated payment was seen to help with 2 large goals for the federal government. One was to lower the rate of growth of costs, which is what the first bullet talks about, and the second was to increase consumer choice. And so what Congress was seeing is that people had more choices in private marketplaces, and so the policy option was to increase choice through multiple insurance plans competing with each other, which would also hopefully drive down the rate of growth of costs. And we'll see about whether this worked out in rural areas or not. It worked well or was perceived to work well in other markets, in private markets. So the idea was to push it into private plans such as Medicare, Medicaid, and then the Affordable Care Act. This slide also shows that as technological improvements happen over the last couple of decades, economists widely believe that this is the major reason why costs rise. And furthermore, this slide shows that much of this is focused on the upper tail of distribution. So the upper tail of expenditures now spend 3 times more than their per capita income. And then also the top quartile spends 400 times more than what the bottom quartile spends. So what you see is a real focus of spending on the top quartile in the tails. And so insurance provides an incentive to behave strategically and to try to get control over these tails of the distribution. So also managed care plans and private options are believed to over time it was chosen that private plans could give the idea of managing care. They could, but the key factor, and you'll see it play out in a lot of our discussion here, with managing care, you need to have a contract with a range of healthcare providers. And another key aspect of this is using prevention as a way to save money in the long run and to manage health behaviors, to try to lower costs in the long run by preventing them in the short run. But a key point to this is that managed healthcare plans have to have provider networks, which will play out in a lot of our later discussion. So networks are key in this discussion, especially when it comes to rural health insurance markets. So that's my sort of beginning of the background issue, and I'll turn it now to Abby, to go through the rest of the presentation.
Yeah, great. So Tim has given us a lot of good background, and I think that the key point from the last slide that we want to go forward with is the idea that at this point, insurance needs to provide access through provider networks, and they also have a really strong incentive to avoid being responsible for the risk of the really high cost upper tail of the distribution. So keep those two facts in mind, and we're going to go forward from there. I think that the combination of markets and health insurance is inherently challenging. Health insurance doesn't necessarily lend itself really well to having a market structure work. There's a couple of different theoretical issues here that come from economics, and so just to talk through those a little bit. The first, the most difficult issue is the problem of adverse selection. Most of you have probably heard of and are probably a little bit familiar with this concept. It's a situation in which healthier individuals choose not to purchase insurance at a given price because it's not worth it to them. And at the same time, sicker individuals are buying more comprehensive coverage. And what this does is to shift the composition of the risk pool to being a little sicker, a little more expensive. And so this in turn then drives the average price up and drives premiums up. So it's a kind of a spiral. Prior to the ACA, in order to mitigate the impact of the adverse selection, private firms adopted several different strategies. Screening and risk segmentation were two of the most common. And what screening means is simply requiring a thorough health exam and a health history so that you could basically screen out the most expensive people and screen out people with, say, pre-existing conditions. Risk segmentation also is kind of a similar idea. It means creating smaller sub-markets in which you have some kind of ability to assess the risk and understand that the risk is at different levels, and then price each sub-market separately. So those are things that happened very commonly prior to the ACA. So even with the market approach, there is potential, though, for the government to place limits on firms' behavior. And so these are the policy questions that we're trying to consider. Direct regulations are a possibility. There are other structures, such as bans on pre-existing conditions. There are bidding mechanisms. There's a whole menu of options for how to design subsidies. There are risk adjustment payments that can be made, several different versions of that. And these are all additions to the marketplace that are meant to incentivize firms to participate in the market under the theory that if you have many participating firms, then competition will lead us to better outcomes. And some evidence does suggest that the market approach with some additional structure, like what I just mentioned, can work reasonably well overall. In MedPAC, they reported in 2016, for example, that 81% of MA enrollees had access to a plan that charges zero additional premium beyond the Part B premium. So that's, sounds like a pretty good deal for a lot of MA enrollees. But we did an analysis of MA plan files from CMS that shows that if you break that down by urban and rural, it's actually 83% in urban areas and only 47% in rural areas. So that's just an example of how it might look on the surface like, hey, this market approach is delivering something really advantageous for consumers, but it might not be evenly delivered to urban and rural people. So to move on from the theory, we want to talk again about the same things that Tim left us with a few slides ago, which are these very rural specific issues and how they play out in insurance markets. So first of all, just to recap what we already said, we have these two functions of health insurance. It is a mechanism for sharing risk, and it is also a means of access to a range of providers who are supposed to be helping to manage the enrollee's health. With respect to both of these functions, the current market-based insurance programs, we feel, do fall short in rural areas. They fall short in terms of sharing risk, and that happens largely because rural places, by definition, have smaller populations and they have lower population density, so risk can't be shared across many individuals. I'll talk more about that in a minute. Also, in terms of access to providers, rural places, again, by definition, have smaller populations, and so there are going to be fewer healthcare providers of all types. So ensuring access is going to be more challenging. I have a couple of little data points there in the green box, just to highlight that notion that there are provider shortages, which I'm sure most of us who are interested in rural health and health policy are already well aware of. So let's talk a little bit more in depth about this small risk pool issue. Why are they problematic? So the issue is really that even though each program has a reimbursement formula that has some sort of risk adjustment component, risk adjustment is a very imperfect science. Even if we had access to a person's full claims history and we were able to use that to predict what that person's spending was going to be in the future, it would actually only predict about half of the variation in future claims. So it's actually still very difficult to identify those people who are out there at the very end of the tail, is what that really means. You can always predict and adjust ex post, after the fact. You can wait till the claims come in and then start, making payment adjustments. But if you do that, what you're really doing is making the government the true insurer. And, you can argue about whether that's a good idea, but one thing as an economist I can say is that it's going to decrease firms' incentives to actually manage care and control claims, which is, ideally that's what we're paying them to do. And so what makes this a rural specific issue is that the smaller the risk pool, the more problematic things become. Firms typically rely upon the law of large numbers, and they're able to forecast the sum of claims that they're going to face. And in a large population, you can predict with a certain amount of accuracy even this upper tail of the cost distribution that's so problematic. So I'm going to walk you through a quick numerical example. So imagine, well, we're talking about 2014 because I have some data from 2014 that says that the top 1% of healthcare spenders had mean spending of about $107,000 each. So that top 1% as a category ranges anywhere from about 75,000 all the way up to about 5 million. And so when you're looking at the top 1%, it could be anything in that range. On average, it's about 107,000. So if you have a population of 100,000 people that you're insuring, there would be about 1,000 who would spend that average, right? That's 1%. And so you can pretty easily guess that the total cost of that group is about 107 million. And it's pretty unlikely from a statistical viewpoint that the sum total there is going to deviate from that, because you have a large number of people, and so there, variations will offset, and you're gonna know with a pretty good likelihood that that's about what you're going to have to pay as a firm, as an insurer. But if you contrast that story with what happens in a population of, say, 1,000 people, you're going to have, again, that 1%, which is about 10. You have about 10 people who spend between 75,000 and 5 million. That's the whole range of the category. But with so few people in that upper tail, we're only talking about 10 people, it's very uncertain whether the average is really going to be close to 107,000. You might have one or two outliers that can move the average a lot. And what this really means in the end is that it's hard to price in the risk, as an economist would say. So in a large population, imagine that you are an insurer trying to sort of figure out how to deal with this risk. You can hedge. You can add say $1 million to your revenues just by charging everybody an extra $10, right? So you can build in this cushion to make sure that you're covering all of your liabilities. In a small population, though, try to do the same hedging, and it's going to cost you $1,000 per person, which obviously would make insurance far less affordable. So just thinking through this stylized example should help to convince you that it's much harder to navigate this in a profitable way if you're in a small market. And so just thinking about this in an environment in which companies are pressured to show a positive return on investment every year, maybe even every quarter. So the reality of managing risk is that there will in fact be some negative and some positive performance over time. But when you're a private company, your focus is to be consistently profitable, to bring in positive profits every single reporting period. And so it really makes it a lot harder to navigate this mathematical situation. So turning our focus now to the idea that health insurance also plays a role of ensuring access. This is also something that creates challenges that are more pronounced in rural areas. And I think we've done a certain amount of work trying to understand what different states are doing and how they navigate this problem. And many states have been proactive in defining what adequate access means in the form of fairly strict, well-defined network adequacy standards. And the federal government obviously also does the same thing, which looks different in different programs. But these standards basically mean that they're assigning the firms, the insurers, to do the work. And you're doing the work and incurring the administrative costs of forming networks of providers who can serve this diffuse population that you're looking at. And thinking about the rural landscape, providers are more likely to be independent or part of small practices, less likely to be part of a large system. And in other words, that means that you are navigating this negotiating process with a bunch of separate providers rather than one. Administrative costs can be spread, again, only over a small number of enrollees. So these network adequacy standards, combined with the sparse providers in some rural places, do create opportunities for strategic behaviors by firms. So we'll talk more about this in a minute. Now, we have anecdotal evidence, I would say, that firms sometimes state that rural providers are quote unquote too expensive, and that's why they need to exit from a certain rural place. And I kind of just want to point out that I think when these discussions happen, the reference point is the negotiated rate that urban providers are willing to accept. So they're sort of using what the urban providers are willing to accept as a benchmark there. So let's step back from that observation for just a minute and go back to economics. And in economics, it's a fundamental part of any cost analysis to distinguish fixed costs from variable costs. So as you might imagine, fixed costs include things like facilities, equipment, EMR systems, certain minimal level staffing costs, just the costs that you need to incur just to be there, just to establish a practice. Then variable costs are those that vary with patient volume. And so that would mainly involve additional staffing, but obviously could involve scaling up, having more exam rooms, maybe extra lab supplies, things like that. So fixed costs, essentially, they have to be incurred as a lump sum. And the provider has to try to recoup them by adding an amount equal to the average fixed cost onto the price of services. So you have to take all of that spending, try to divide it by the patient population, and add a little something to each bill to cover that, right? Variable costs, on the other hand, are flexible, and they may be recouped as a part of the marginal cost of seeing a patient. So when you think about those types of costs, and you think how providers can bill, you can see how the problem would happen. The current market-based models really do encourage marginal thinking, right? And from an economist's point of view, that's not necessarily bad, but in this rural context, you're encouraging the firm to assess the cost of one more person against the benefit, and the benefit for the firm is the premium that they'll receive for enrolling that person. And even when premiums can vary by geography, for example, in Medicare Advantage, the benchmark is actually different in every single county. What the government will pay to the Medicare Advantage plan differs at the county level, but firms are still going to want to keep their premium and their bid as low as possible. And that actually does create an incentive to pressure rural providers to accept lower rates. So if the provider is actually needed in order to maintain some kind of network adequacy standard, then they're going to get that pressure to accept a lower rate based upon what the insurer is used to giving in a more urbanized area, or they may just omit the providers who can't accept the lower rates. If the provider is not needed for network adequacy, then that would be an explanation for some of the data that we see. Okay. So stepping back from all of that, I want to talk a little bit about the real-world rural impact, and then we'll be concluding with some policy opportunities and recommendations. So as I said a few minutes ago, the geographical unit for Medicare Advantage is the county. Firms are bidding against a benchmark, and that benchmark is tied to prior data on fee-for-service Medicare costs in that county, right? So depending on what the Medicare fee-for-service costs have looked like, the firm might have an advantage. They might have, there might be a pretty big cushion or a pretty big margin, or not. But what this does is it encourages the firm to treat each county as a marginal decision. Should we enter? Should we stay? Should we exit this particular individual county? So moving on to health insurance marketplaces, under the ACA, the geographical unit here differs in different states, but I would say the most common rating area there is a group of a handful of counties, maybe 5 to 10 counties, and the most common structure is a metropolitan or micropolitan area plus some outlying rural counties. State regulations do vary quite a bit on how strict they are in terms of whether the firm has to offer the coverage actually throughout the rating area, or whether they can omit certain counties if they want to. I know in Missouri, where we are, firms can actually omit particular counties within a rating area if they say that they are not able to meet the network adequacy standard there. That's true in several other states as well. So the benefit of a larger rating area is obviously a larger risk pool, and that's beneficial for reasons that I walked us through a few minutes ago with that numerical example. The possible problem with a larger rating area is that then you have to form a network that can cover the larger rating area, and I've also discussed a little bit about how that can be problematic. So the process of negotiating reimbursement rates, obviously it's ultimately depending on a number of factors, but the ones that I want to focus on here are the market position of the insurance firm and then the market position of the provider. If the firm is accustomed to reimbursing marginal costs only because they have a lot of contracts with more urban providers who can essentially draw their costs down almost to that marginal cost point, it may refuse to contract with a rural provider who needs those fixed costs covered. The bargaining power of the provider is weakened when they're heavily dependent on public dollar programs So in some areas where a large majority of the funds come in from Medicare and Medicaid, the provider doesn't really feel like they have any wiggle room to say no. So they feel like they need to accept whatever contract is offered. The bargaining power of the firm is strengthened by policies that limit their exposure if they fail to contract with a provider. There's a couple of headlines there that refer to cases where these things have happened. So this first headline is actually a very recent one in Missouri. That headline is followed by an opening paragraph that goes like this. It says, Missouri is changing the terms for how healthcare providers are paid after caring for certain Medicaid recipients, a move some rural hospitals warn could lead to financial losses. If providers do not come in network with the 3 insurance companies contracted by the state to provide coverage for certain Medicaid recipients, providers will be paid 10% less than they're used to. So that's an example of changing the structure in a way that very much shifts the balance of power in these negotiations. The second headline is a similar sort of story. Medicare Advantage plans are underpaying rural providers. That's a story from Modern Healthcare earlier this year. And the example there was kind of a similar situation where the managed care company, or sorry, the Medicare Advantage company plan doesn't need to contract with the local hospital because the rate that they have to pay if someone goes there out of network isn't particularly high. Like it isn't even as high as fee-for-service. So those are the kinds of things that you have to be really careful about when you're designing policy and make sure you think through how that's going to impact rural places. So in the real world, obviously prices are negotiated for a continuum of different healthcare services of varying degrees of complexity. And I think similar to other industries, this gives the larger providers, in this case the larger hospital systems, the incentive to behave strategically in order to undercut smaller local providers. So let's think through this specifically. If you can offer a marginal cost or even below marginal cost pricing on the services that the smaller providers, places like critical access hospitals and rural clinics, so basically you undercut on the services that these other guys are able to provide. And then you make up your own fixed costs on the complex services for which they don't have any local competition. So, you know, that is something that is very difficult to unpack and figure out how you would prevent the different actors in the market from trying to engage in that type of behavior. I mean, that is logical, strategic behavior for a profit maximizing firm to try to do. So the result is that it undercuts the local provider's ability to stay in the market. And it also at the same time is conveying to the insurer the sense that that local provider is too expensive to include in the network. So, you know, that's the problem that occurs when you start looking at these policies in the real world setting. So where does that leave us? We do have a few policy opportunities to talk about. And then at that point, we can take any questions. So if you have questions on anything we've said already, or if you want to discuss these opportunities and recommendations, please shoot us an email. So first of all, this should probably be obvious from what we've said already, but we're in favor of spreading risk. So if we can spread risk across rural places, we think that will be beneficial to rural enrollees in all these different programs. It could even be possible to spread risk across programs. That would require a lot of innovative policy making, but it could be done. Multi-state rating areas, in particular in the health insurance marketplaces, but you know, you could do that in any of these sectors. And another way to do that is to require the rating area to be the actual service area. So you don't have this mismatch where the state has designed a rating area and yeah, it's got a metro or a micropolitan area and it's got some rural counties outlying it and it looks kind of like it should be a natural service area, and yet certain counties are being omitted. So the state could easily require that not be allowed to happen. We could also look at providing incentives to form nationwide plans. In the original Affordable Care Act, there was supposed to be what was called multi-state plans, and after 4 years of operation, there was supposed to be a multi-state plan that covered all 50 states. That didn't happen, and I think one reason that didn't happen is that there really weren't any particular incentives built in. There wasn't a big advantage for any firm to say they were going to be that multi-state nationwide plan. But we could probably figure out some incentives that would encourage some of our bigger insurers to take on that role. We can also think about adjusting payment policy to reflect the reality of fixed costs in rural. This is just a fundamental issue that policy, reimbursement methodologies can be tweaked, can be fixed to take this into account. You can do this at the provider level. You could think about it at the clinic or hospital level. You could even branch out and think about the public health department level. You could think about, fixed lump sum payments that should provide that baseline level of, being able to stay open, basically, in a rural area. You can also invest resources into rural provider affiliations so that firms, when they're negotiating to try to establish network adequacy and form that network that meets all the standards and checks all the boxes, that they can do it with fewer sets of negotiations. If they can contract with a provider affiliated group all at once, that might lower some of those administrative costs. Another way that I think would be really a innovative and consumer-driven approach is find a way to be very transparent about network adequacy. Because I think implicitly, when we talk about these two issues, the roles of insurance, we assume that consumers are able to sort of vote with their feet or vote with their wallet, let's say, by choosing the provider that has the network that suits them better. But the reality is, of course, that that consumers don't really have all that information at hand. It may be the case that rural people are willing to tolerate a longer travel distance when necessary for specialty care, but they might actually have strong preferences for local providers being in network so that they can go to those local providers for routine and low acuity care. So just to kind of step to the side here and look at this picture for a minute, this is a screenshot from an organization that is, it's all about answering this exact question. It's about transparency in terms of networks. And I think that what contracts they have so far, if I'm remembering right, are with the state of California's the office that oversees the Medicaid managed care companies. And so what they are doing essentially is auditing provider availability within those managed care networks. And so I had a couple conversations with them, and they produced this map of Missouri for me, since that's the state that we look at a lot. But essentially, if you could facilitate some type of information exchange that would allow consumers to see, okay, if I sign up for this company, here's the amount of driving time I'm probably looking at. Here's where the providers are relative to me. Here's the primary care. Here's the specialty care. And then you might look at the rating of another competing company that's also offering plans, and maybe you see that you have to pay $15 more every month, but the network adequacy, the network availability is much stronger. And then you would have that trade-off visually available to you so that you could make a better choice. So I think that's another interesting idea that needs to be explored further. So actually that brings us to the end of our official presentation. So we can take questions if anyone has questions for either Tim or me. about any of the slides, I can go back and we can view any of the slides that someone wants to focus on.
And if I could add one more quick thing on this, I know we covered a lot of dense material in a quick amount of time. There's a paper on this subject that you can find on rupri.org. And also we have quite a few papers on looking at the insurance marketplaces, Medicare Advantage, FEHBP, and other rural marketplaces. So you can explore some of the concepts we've talked about in detail with some data. So we can open it up for questions. We didn't have any questions emailed in that I've seen.
Yeah,
so,
haven't seen any yet, but please feel free.
Feel free to jump in. We finished pretty much how we planned at about 12:45. So. I guess we are perfectly clear. Huh?
No one wants to email.
While we're waiting, I think, just to accentuate the final, the sort of key points is what we tried to tackle a large subject here. And I think Abby was lead author on this work. And, the team that we've had looking at this again was try to draw parallels across these marketplaces, because the policymakers and federal and state governments have looked to to these private options as a way to, again, reduce costs, growth, and increase choices. And I think there are some successes, but I think, the headline that I would say, that I often say when I make presentation, is there are special challenges when it comes to rural areas, these many counties in the US that are rural. And we've tried to accentuate why we think that these challenges occur, and I think it's mostly around population density and the ability to form networks and a few other major challenges. I don't think that it's impossible to deal with those problems. We've laid out some options, but that's sort of our main point.
Well, I still don't see any questions, so I hope that the emailing didn't discourage anyone. But if you think of a question later, please feel free to contact us. And I guess we will sign off at this point. So thank you all for joining the webinar, and I hope you found it useful.
Feel free to email us again if you have any questions. Have a good day.